Hi, everybody. This is Susan Clinton, one of your hosts for Tough to Treat. And this is podcast number 169. And it's not a terribly long podcast, but it brings home some important points about why we need to ask deeper questions with our patients that come to us with, typical chronic low back pain. And that's what this podcast is about. So I also want to thank you for joining our website and downloading podcasts. Please leave us a review. It means the world to us to help other people find us. I appreciate it. Thank you very much and enjoy the podcast. Hi, everybody. It's Susan Clinton, one of your hosts for Tough to Treat. I'm here with Erica Mello. Hi, Erica.
Hi, Susan. How are you?
I'm good. We're still plugging away through summer. The time of this recording, we finished the 4th of July, and I know there are parts of the country that are deep into some really awful heat. We're sending you thoughts that will help you stay cool.
Yes, for sure.
At this time. But anyway, let's get on with the podcast today.
Let's do it.
So this is kind of a conglomeration of some clients, but there's several things that have stuck out through the years with seeing them. These are clients that always get referred to me because people are not quite sure what to do. They don't respond. And, so they end up finding me just like they find you, to see what else can, be done. So this particular one that I'm thinking about is a lady in her late 50s with chronic low back pain. No history of injury, insidious gradual onset, plus, for 20 plus years. Some months and years were better, some months and years were not. The whole story, It's always there. Sometimes it's better. So I tried doing swimming. That seemed to help for a while. Sometimes there was a time when I was doing yoga that helped. There was a time when I rode my bike a lot. So activity seemed to make it a little bit better if you kind of listen to her story deep in. But it was just interesting that she was talking to me a little bit, it would go in cycles, where it would ebb and flow as far as it went. And, trying to get people to pin them down to do a 20-year history is a little tough. Yeah. And I just asked for the high points, was there anything outstanding going on in your life when things were not as good? And one of the things, she could only remember recently, and then she would remember a few things in the past. But one of the things that stuck out to her was when I wasn't as motivated to exercise, the pain always got worse over time. I would just oh, that's enough of that. It really hasn't changed my pain. And then I would not do things for a while, and then my pain would get worse. And I'd realize, oh, that maybe it was doing something for my pain.
Yeah.
And, whenever there were times of stress, things seemed to feel worse too. There was a period of time where she had pain for a long time, and her husband had been really ill during that time, being the main caretaker and the kids, and there was just a lot going on, so she could mention, a few times like that as well. There wasn't anything, it's not really stopping her from doing a lot, except that it does limit her response of yes to things. So she's not going to say yes to going hiking, but she will go to the grocery store and walk, and she will, go ride a bike some, and go to dinner with people and things like that. But she does, say that she's her world is closing in a little bit. So the reason that she was seeking physical therapy again was that she fell 6 months ago.
She fell. Wow.
Yeah, she landed onto her hands and knees. Not really, it was in the grass, but it was still, it was a good fall. And she said things just have not been able to be settled down. Even moving more, trying to exercise a little bit more, doing her old tricks haven't helped. She's been back to 2 or 3 different PTs who have all done dry needling and mobilization and, core exercise, and not really making any headway.
And when she fell, Susan, it was her low back that she still felt afterwards.
Yeah. So no wrists, no knees, nothing outstanding, nothing, worse. She did have an x-ray. Some people told her that she should go and get an x-ray because she could have fractured something. She did have an x-ray. She didn't show any compression fractures in her back, because that was the first thing I thought. I wanted you to fall onto your hands and knees,
Mhm.
and kind of talked a little bit about bone density, but
Yeah.
no compression fractures or fractures of any sort. So,
Mhm.
and it wasn't like that type of pain.
Yeah.
She said, it was like my normal pain that I'm used to just has ratcheted up, but it wasn't like, like she could still walk, she could still bend over, she could still do things. If you had
Mhm.
a compression fracture, you're not doing any of that stuff.
No, no, no,
The fractures don't like compression, nor do they like traction.
no.
So anyway, and I just asked her a little bit more about her life, her health. Has she ever tried changing her diet a little bit? Like, what kind of food is she eating? Is she eating a lot of inflammatory foods? Does she have a stress management practice? Just some different things, just to get an idea of what she's done, how she's coped with this, what she's
Right.
managed, what she's willing to think about. She said that she's tried the chondroitin,
Oh,
glucosamine.
glucosamine, yeah.
Yeah, didn't really seem to help much. She definitely takes vitamin D. She definitely like eats foods that are rich in calcium. She's aware of those types of things. She definitely, does some vitamin C and things like that. She doesn't eat very unhealthily,
Mhm.
but she does. It did lead us down a pathway to a conversation that I was hoping it would lead us to, because everybody always wonders, how do you start asking pelvic health questions to somebody who's not talking about pelvic health issues?
Right, right.
And this person has been constipated for 20 plus years.
Oh my gosh.
So, right, she's
Wow.
been constipated. And so there's something that came up because we were talking about food, and I just asked about elimination. And she
Mhm.
said, oh no. But the thing that's really stood out was that she could always go to the bathroom about once or twice a week. But since this has happened, it's like she's lucky if she has a bowel movement, in 7 or 10 days, and then she has to take a bunch of stuff to move things out. So she
Wow.
has been to a GI doctor, which was interesting. She's
Yeah.
like, asked her about her history, and she never told me about any of that. And they want her, she's been on Miralax. They want her to, if she can't go to the bathroom at a certain time, she has to take stool softeners and,
Mm.
a bit of a balm to move things through. And then
Yep.
she's okay for a while. But, with this whole 20-year history, and there's somebody here with chronic low back pain, it was never addressed. And that's the thing that I just
Hmm.
want to bring home here. Is like,
Yeah.
when you have people coming in with back pain, whether it's insidious or not, most of the time it's insidious, though, or at least to them it is.
Yeah.
You don't associate these two things together.
Mhm.
Most people just think about back pain when bearing down, like a Valsalva. And that's not what we're
Mhm.
talking about here. We're talking about, when people have chronic low back pain, you've got to look at the GI system and see what's going on.
Mhm.
And they've done different studies about this throughout the time. The biggest one was back in 2007 with Maggie Smith and Paul Hodges, and looked at people, females, cross-matched them to gender, to, well, of course, gender, but to ethnicity, to age, to BMI, to all of these things. And they found that people with chronic low back pain, 78% of them also had chronic GI issues. Now,
78%.
that's a
Wow.
lot. That's a
Yeah.
lot. That's more than, yes, it's still
Significant.
correlation. You can't say, oh, this back, the constipation caused back pain. You can't say the back pain caused constipation, but they do have a couple of things in common. And so, for instance, in her exam, her back was limited in all directions. It hurt. She has stiffness. Was it stiffness because muscles have shortened over time? Was it stiffness because she was just unwilling to move, in
Yeah.
free range of motion?
Mhm.
But what really stood out was she really did not have a lot of mobility in her thorax. And I
Mm.
know you and I have talked about stiff thoraxes and low back pain
Mhm.
in the thighs a
Yep.
lot of times. She has had 2 kids who knew when the thorax got stiff. But one of the things that struck me the most about it was thinking back about when you have chronic low back pain, you've got muscles that are inhibited.
Yeah.
Like the multifidus is probably on her, pretty well infiltrated and isn't operational after all these years. And so you have other muscles that are working too hard, like her erector spinae muscles were like, working to beat the band. Her abdominal muscles were not working, not very well. She had a bit of a distended belly. And then, when I asked her to take a deep breath in, her ribcage wouldn't expand. Her belly expanded a lot, but her ribcage did not expand. So it leads me to start thinking like, okay, so what's the common denominators here between maybe this constant chronic pain and this chronic constipation and all of the things that, we can see, but how can we handle this as a physical therapist? And so, the swelling, the abdominal distension is telling, because it has learned to, with the chronic constipation, the inflammatory piece from that, I asked her about that and she said, it's always worse in the afternoon or evening when later in the day. It's always better in the morning, always worse later in the day. And I said, do you notice it more when you eat certain things? Not really, but I haven't really paid attention. So, so that was one of her things, was to look for trigger foods.
Yeah.
But the other piece of this is I asked her if it was painful. And she said, nobody's ever asked me that. And I said, well, tell me your experience with this. And she said, it's always uncomfortable. It always, I feel discomfort. They always feel like I have a lot of gas. And it just feels like, by the end of the day, it gets distended. And I said, does your back hurt worse when this happens? Well, hard to tell, because she wasn't equating the two. So she hadn't looked at those together at all. Yeah. And I said, well, let's just say they're two separate things, but they're both impacting each other together.
Yeah.
Can we kind of go on that postulate here? Interestingly enough, she never had any problem with stress urinary incontinence, which is good. So that means that, at least, there hasn't been, because with this pressure kind of system problem of constipation and having higher pressures in a low pressure organ, which is the abdomen, just really looking at that from that point of view. But she does have, does have problems like straining and trying to move stool out. It's not uncomfortable to have a bowel movement, but she really just it's always difficult to have one.
Yeah.
And so she's never been to anybody to talk about this. And her GI doctor just, did a colonoscopy. She did the full clean out. There was nothing organically wrong. He just, chalked it up to functional bowel disorder and told her to, take the Miralax and get things moving and, put more fiber in her diet.
Yeah. But they never actually make the link to the rest of the chain, and especially with the thorax. It's so interesting because I was just reading an article about, it was just for my doctorate on, applying in patients who had chronic low back pain. And they put them in two separate groups. I'll make a long story very short, but one group got thoracic. So it was basically outcome measures were respiratory function. Okay, chest wall excursion, FVC, forced vital capacity, the oswestry, and sustained inspiratory maximal pressure. The group that had basically, Susan, just PA, joint mobs, Maitland, grade 3, nothing fancy, to T1 to T8 had significantly greater improvements in all respiratory function over the other group. Okay. And they didn't measure GI, but I'm trying to make an analogy. It's that people, it's just so important to look at the thorax. Anyway, I'll let you go. I'll let you continue.
And that leads us to the really good reason as to why maybe those input to the nervous system at that thoracic area made such a difference for respiratory input and output. Probably because there's innervations for the diaphragm all the way through. And, so it may have, given the nervous system a chance to kind of wake up and get the diaphragm moving again, but the diaphragm isn't going to move if the chest wall's stiff.
Yes, that's right.
Or the chest wall gets stiff because the diaphragm isn't moving.
Yeah. And all those outcome measures were significant. I mean, statistically significant. And you talk about like the bracing of the lumbar spine, what that does is that also reduces the length tension relationship of all those muscles, gives you an image of quote unquote stiffness in the thoracic spine when it's really muscular tightness.
Yeah.
And it affects the whole, GI system too. And, yeah, go ahead,
So
Sarah.
yeah, so orthopedically thinking about the spine, the diaphragm becomes a postural control muscle,
Yeah.
which means the crust of the diaphragm, which is where the esophagus and the aorta and everything goes through, is more at the posterior aspect of the diaphragm. That whole piece lifts up and gets pushed towards the spine.
Mhm.
So now we have a link tension relationship problem in the diaphragm,
Yes.
and it's
Yeah.
harder to breathe. So there's the recruitment of the belly to like pull the air in becomes higher as well. But here's the other thing with the chronic constipation and the discomfort with the gas, we're talking about an allogenic response of the lumen of the intestines. So in other words, gas is normal. And when we have normal amounts of gas, what the human body does is they have actually a tightening, or almost as simple as kind of a bit of a bracing of the abdominal wall, and actual increased movement of the diaphragm to move the gas through. But when it's uncomfortable and it's been there for a long period of time, we have the opposite. The belly relaxes to pull away from the discomfort because it's what's happening in the lumen. It's uncomfortable, but the response of the body over time chronically is to pull away from that, not press against it. And when they do that, the diaphragm tightens up.
Yeah.
Called abdominal phrenic dysynergia, just like what the diaphragm does with pain in chronic low back pain, from the Kohler articles and the work done there. And so when we talk about that, this is how I want to kind of get the people who are, looking at these people and kind of wondering, why do I need to talk about this with people? Because you've got two sets of dysynergias that are being set up here. The diaphragm is super stiff, the thorax is stiff. They're doing this tremendous amount of belly breathing, which isn't helping the abdominal wall regain control. And and on top of it, the top of the abdominal canister is being held like a very tightly screwed in cap on top of it, and the pelvic floor has no other function except either to do one of two things: either fall out or to tighten up and push against that.
Yeah.
And which makes for them not being able to relax their pelvic back passage enough at the pelvic floor to go to the bathroom.
Yep.
So the other interesting thing that I noticed with her was a lot of balance issues.
Oh,
Standing on one leg. And you can just picture this, can't you? If somebody's got a bit of a distended belly, a very stiff thorax, they're not going to have good side to side balance. They're just not going to be able to. So, this person fell. Why did they fall? Did they fall because they tripped over something? Did they fall because they couldn't regain their balance? This is a good point. It gets me. It's like, okay, we deal with the aftermaths of the fall, but what about why they fell?
Right.
So I asked, so after I did some of these balance things, I asked her, I said, tell me about your fall. And she said, it was just so fast. I didn't even see it coming. 1 minute I was up, the next minute I was on the ground.
Yeah.
And I said, did you trip over something? What happened? She goes, I have no idea. She goes, I don't know if I tripped on something. All I know is I went down. I said, well, where were you? And she was on a field walking. So she said it was uneven.
Oh, wow.
And she said, but it was good I fell there because it would have been horrible if I'd fallen on concrete. And I was like, well, I'll give that with you.
Yeah, exactly.
But to me, it's like, okay, we not only need to help her solve her constipation problem, but we got to work on breath. We got to work on this thorax, and get so the diaphragm can actually move again. We've got to give it a better nice.
And she can get better, exactly. She can get better AP and medial lateral control when she's about to step on a log or something like that, right?
Exactly. So the interesting thing was just taking her back through her story, was enough to bring in the balance piece too. But there were three things that needed to happen here. She needed to regain control of her abdominal wall. She needed her diaphragm to return to being a respiratory muscle. She needed her thorax to take the pressure off of the lumbar spine to be much more mobile. But she also needed to gain rotation in her system and be able to be reaction, have that reaction
Reaction
response
time,
to balance issues and things like that.
yeah. It's almost
So
like
it didn't look like a typical low back,
I was just going to say
mobilize the
that.
low back, dry needle the low back, do these things
Yeah.
type of person. This became a whole body kind of movement experience for her.
Yeah,
Gain everything.
It's like the perfect tough to treat patient in a way, because it's like a three-pronged approach. Because even with her history, when you see these patients, well, sometimes I did that, it was better. Sometimes I did that, it was better. There's no one, this is it, and this is what you got, and this is one treatment and you're done, one and done. That's not her. And I know she's in their 50s going probably, or she's late 50s, she's in menopause or out of it, right?
Yeah.
So, this is a whole other episode, but balance is so important, and it leads to so many other issues in life. But I like the interesting part about, for me, was the diaphragm piece, because after reading that article for my doctorate, I was like, it's so interesting how they grouped these two groups. But the important piece was, intervention in the thorax helped. You should see the bar charts in this article, significantly in the oswestry, the outcome measure, just significantly, with just the addition of joint mobs. You don't have to do joint mobs, whatever intervention you want to do in the thorax, but it reset the whole system. It was astounding. And I would be interested to see, maybe for a study, the relationship of balance and, the GI system and the diaphragm. That would be a massive study, but it would be interesting to see, even if it's a case report series, if any of our listeners have any cases like that, feel free to reach out to us. It'd be great. We could discuss them on air. But I think it's interesting to see, and because we see it a lot now, right?
Yeah, absolutely, 100%. And I think here's the thing. I love the fact that they did oswestry.
Yeah.
I love that, because what happens when the sympathetic nervous system is in overdrive? We're running from the tiger, right?
Yeah.
So if we have that chronically going on, that's going to stiffen up the thorax, because it's not going to move. It's not going to have the depth and breadth of motion because of the way that it's working so much. So when we think about that, and we think about what also goes along with the sympathetic system, is fear of movement.
Yeah.
Like, what are they, are they unwilling to move because they're afraid? And when you give them mobility through that area, and all of a sudden they can take a deep breath for the first time. And we know the one thing that'll really knock that sympathetic nervous system out of overdrive is breath work. But you got to give them the frame to do the breath work.
Yeah, and ultimately, I think it's very interesting. I don't do this. I put my hands on the thorax, I look at chest excursion, but do I take a tape measure out? No, not really. They did this for the study, but I think it's just important, have your patients take a couple lateral costal breaths, do some diaphragmatic apical chest, just to see, just close your eyes, and is one reduced. You don't have to tell the patient why you're doing it. You can do your own little mini study, and treat the patient and see if that gets better. If it doesn't, you need to directly intervene in the thorax. They can have foot pain, for God's sakes. Doesn't matter. You do your own little mini study, and I think it's important to restore normal breath work, because when someone's afraid, what do? They hold their breath.
Yeah.
If they're afraid consciously or unconsciously, they hold their breath.
And it's interesting, because all of these movement things out there, like these full body movement, lovely stuff, that are all based on, just like the whole body moving and moving in harmony. So if you want to get into Qigong or Tai Chi, yoga, whatever, any of them, all of them, there's so many out there. But all of them, will tell you that if you don't have balance, you're holding yourself stiff somewhere.
Yes.
If you can't balance, there's tension in the system. Find the tension, resolve the tension, and return to the balance.
Yeah. It's almost like that. An old article I read, of speaking of Paul Hodges, about the feed forward mechanism in low back pain. That's the thing you literally have to increase your reaction time, right? Whether it's for balance or just reaction for postural control, it's important. So
a reaction for cognitive control.
For cognitive control.
Right? That there's so much now out there about movement but reactionary movement. It really improves cognitive processing.
Yeah, it does. Absolutely.
We don't do enough of it. We do a lot of anticipatory movement. We don't do enough, reactionary movement.
No. Yes, exactly.
And so that makes me bring up my favorite thing, which is the Clock Yourself app.
Yes.
If you all are new listeners to Tough to Treat, go back and listen to other episodes. I talk about it a lot, but get that app and play with it.
Yeah. Yeah.
It's got so many cognitive and physical pieces to it, and it can be as slow and as easy as your patient exactly where they are with it.
Yeah, I love that.
That's exactly what we did. Was we got started with that.
Yes, I bet.
And started increasing her sphere of movement and things like that. And
yeah,
again, got the thorax going. Really worked on some of the ways to get the abdominal wall to begin to gently pull in. And be able to take a deep breath while that's actually happening, to retrain that whole system a bit. But the biggest key there was for her to really relearn how to do some breath work that just involved the thorax moving. Because we breathe all day long. So if we can get the thorax moving with our breath, this is self-mobilization.
Totally. Did you get the buy-in from her initially when you explained all this?
I did, because we kind of did it together.
Okay.
We did it in the form of storytelling. Like, as she would tell her part of the story, I would kind of just reflect that for her so she could hear it.
Yes.
And then when I told her, I said, we have two different things going on, but they're both impacting everything the same.
Yes.
And now we have on top of here, this not going as well, and it's being reflected underneath. So she's going to have to manage her constipation for life. That's been too long for that to just pop open and be good. She did get to the point to where she could sit comfortably with her feet up on a stool on a toilet. She got better at learning how to manage fiber, not doing psyllium husk or chronic constipation. It sets up like concrete, but instead chewing her food, being good about eating slow and relaxed. Finding her trigger foods, removing some inflammatory stuff. But that combined with the breath work and the movement and her recognizing the stress in her life. And those were the things that, getting to those foundational pieces was what she needed. But the biggest thing for her was we really worked together to design a program that would allow her in her life to gain more rotation. And to gain better breath. So that she could be free. So she didn't have to live all compressed down. And it was fun. I sent her off to one of my very favorite movement people, in the area where I was living. And, I said, go play, go have a good time. It's going to take you into directions that you're just going to really love. And, so things like, somatic movement can be so helpful for people. She, down the road, she probably needs to load, but that's another story for another time. But, the biggest thing is that we really just needed to get her freed up, and I think a part of that was like some of it could, we talked a lot about, did she really think that, was a mental health therapist, something that could help her, It wasn't something she was ready to explore, but she was open. Because when she realized, about how just even her thoughts, like we get into pain neuroscience education, how your thoughts can be so self-limiting, and threatening. And she would, she kind of almost realized that, I look at that couch in the living room and I think, oh my God, I can't sit there. So it's like, then she also realized that how that was affecting her, saying like, oh, they want to go get on a boat. How would I possibly get in and out of the boat? I am going to say no. Instead of like, I got to figure out how to do this. I want to do that.
It's asking yourself a different question. That's, reframing it. That's really what it is. That's what a lot of patients, not just her, I'm just having a light bulb moment here, patients need to reframe their questions, and we need to reframe how we ask questions as well. That's a whole course in and of itself, but that's she's looking at it from a different, how can I figure a way out to do this with instead of self-limiting and saying, I can't get in the boat, I can't do this. It happens to all of us, but it is much more, and I hate to use this word, but empowering to ask the question from a different perspective, because you'll see it, you'll have many options, and it's better for your mental health that way, I think, as well. I mean, do we do it all the time? No, but it's a good habit to get into. I think. So,
And it's one that's really empowering for you and your clients.
yeah.
You know,
And
if you want to have fun being a physical therapist out there treating these tough to treat patients, you can. It doesn't have to drain you. You know, you're not there to fix them. You're there to help them understand
yeah, yeah,
what the possibilities are that they can begin to do and how that will impact them.
yeah,
Let them to, you know, once they feel like it's relevant to them, they're going to do this stuff and they're going to figure out how to do it. All I'm doing is introducing and showing her a different way, guiding, and it's up to her to take off with it. You
yeah.
know, like, you know, the deep breath and the nice breath and the breath work was really impactful for her, but she
Totally.
couldn't do it before until she could
Yeah.
get some motion in that thorax.
Yeah, and exactly. And I mean, breathing is a musculoskeletal act. It really is. It
Mm-hmm.
really is. You know, it should be, you know, an integral part of any therapist assessment, whether you're coming in for foot pain or whatever. But for her, she didn't, you know, she got it. She got it. And I think some patients need a little bit more convincing about that.
Mm-hmm.
They're like, oh, what do we do about the breath? And I'm like, well, I think you need, you know, I think you need to do it. And you have to convince them of that. But it sounds like she didn't need that. But it was awesome.
Thousands of research articles will tell us different.
Totally.
It
Exactly.
really is about the breath.
It is. It's muscular. It's an MSK, as they say, musculoskeletal activity. It's great. It was awesome. Well, thank you, Susan. Wonderful case.
Yeah, thank you, everybody. Thanks for listening. Love to hear your input.
Yes, reach out to us.
Leave us a review, help others find us, and pop in and let us know if there's anything you want to hear about.
Yeah, and the website's, oh, I'm just gonna say the website, toughtotreat.com. And if you have any, if you are a new listener, just pop in there and all the episodes. If you have an interest in hip labral tears, you type that in the search bar, and whatever episode that has those keywords in it will pop up. And we have a two PDFs. If you don't have them already, you can sign up for them. It's a Clinical Pearl PDF that I wrote, and a one that Susan wrote on sleep and persistent pain. So you'll get those for free when you sign up. But there's a wealth of knowledge on that website. I mean, we're almost at 170 students, so there's got to be something there for everybody on that website.
Yes, 100%.
All righty. Thank you.
Yes. Thank you, everybody.
Bye.